All right, everybody, thank you for joining us. I'm Dr. Søren Estvold here at Augusta University in beautiful Augusta, Georgia. I'm a family medicine doctor and transgender LGBTQ medicine doctor. And this is my partner, Priscilla Bigol. She's a fourth-year medical student at UMHS.
Yes, hello everyone. Thanks for joining us today.
So for those of you just tuning in, we're going to give about an hour-long lecture on LGBTQ medicine. We've done this presentation before. We love it. We present it all over the hospital. We like to look at it as like boot camp for LGBTQ medicine. It's not just medicine. There's a lot of like medical theory behind it. There's a lot of cultural competency that we talk about. Basically, if you're a provider and you're very uncomfortable with doing LGBT medicine or treating LGBT people, like this is a great presentation for you to kind of break through that barrier. So let's get started.
So full spectrum medicine. So we're going to talk about a lot of, I'm sure a lot of you guys have never really experienced LGBT medicine or come up with a bunch of patients that feel uncomfortable. And that's essentially the whole thing that we're talking about, is making you guys feel comfortable enough to treat these patients, but also so the patients know that you are a safe zone for them. So does anyone know what LGBTQ2SIAAP plus stands for? It's very long.
So let's run through it. And if you guys have any questions throughout the presentation, go ahead and chat in or type us a message and it'll get to us.
Yeah.
So let's break this down. Priscilla, what does L stand for?
Lesbian,
G,
gay,
B,
bisexual,
T,
transgender,
Q,
queer,
second Q.
questioning.
How about 2S?
Two-spirit.
And two-spirit's a relatively new idea, kind of. It's a very old tradition in the Native American population, but it's now getting its moment kind of in medicine and in culture. And it's this concept of being not necessarily transgender, but of being on the spectrum of gender identity. So it's not necessarily binary, but it's also not necessarily transgender, but it's a Native American cultural idea. All right, what does the I stand for?
Intersex.
How about A?
Ally.
Second A.
Asexual.
P.
And pansexual.
And plus.
For everyone else.
So as you can see, this is a huge alphabet soup. This is the largest version of this word that we know of. If you don't know what all of this means, you can simply use the word queer. That's kind of an umbrella term that encompasses all of this. For the purpose of our presentation, we'll be saying either queer or LGBTQ. But in reality, we mean everyone on this gender sexuality spectrum.
So there's some labels that we've already gone through. So L is in lesbian, G for gay, B bisexual, T transgender, Q for queer, and then plus for everyone else. So just kind of keep that in mind if you don't know what they are.
So where do drag queens and drag kings fit in on this spectrum? A lot of people, and the reason I put this slide in here, a lot of older physicians tend to lump drag queens and drag kings in with the transgender population. And that's not true at all. A lot of these are people within the LGBTQ population, but they do drag for performance value and entertainment value, and they're not necessarily transgender. Now, they could be, that's entirely possible, but for the purpose of what we're talking about then, we're gonna talk about drag kings and drag queens as a entertainment value, not as a transgender part of the community, okay?
So some definitions that you should be aware of. So transgender is when the gender identity is different from biological sex. Gender identity is how one views their gender regardless of their sex. And sexual identity is who they're attracted to. So their sexual orientation. Cisgender is when the gender identity and the biological sex are congruent. And then, so the new terms, so we talk about the transgender populations, how male to female transgender. So we now say trans feminine for male to female. And then we used to say female to male transgender, and it's now transmasculine. So those are some terms that you should start to use in your notes or when you start to describe the patient. So if you have a patient and you're presenting to your attending, you'll say 25-year-old transmasculine patient comes in today for. So it's a little bit more,
It's modern.
it's modern.
We like to move away from the use of saying like, this is a transsexual person. That's that's a very outdated term. Saying someone is a transgender patient is okay, but saying they're a transmasculine male is definitely more specific.
Yeah.
Saying they're a trans feminine woman, you know, lets you know what their transition was and where they're at now. So definitely use those terms whenever you're talking about these patients. So let's go over gender theory. This is the Gingerbread Person. This kind of helps for all those visual learners out there, kind of see a little bit better what we're talking about. As you can see, gender identity takes place kind of in the mind. So it's how you identify yourself. Attraction takes place kind of more in the heart. It's who you're attracted to, who that other person is. Sex is more biological and has to do with the organs that are present. And then expression is how you present yourself to the world. So you can see, I keep referring to this as a spectrum of identity because you can mix and match all 4 different expression, identity, attraction, and sex and get different combinations of sexual identity. And so we're going to explore that in a little bit. Now, has anyone heard of the Kinsey Scale? The Kinsey Scale is actually an old theory from the 1940s. Dr. Kinsey was a researcher who looked at sexual orientation, and he collected a lot of data on sexual orientation from people. And he found that sexual orientation was a spectrum and it was not binary. This is important because he identified people who are exclusively homosexual. They're at the 6 end, they're at Kinsey 6, and then exclusively heterosexual, they're at Kinsey 0. Now, that's great in terms of labels and everything, but what was really important about his findings was it actually gave rise to the concept of bisexuality, where someone's a definite Kinsey 3. So they don't identify exclusively heterosexual or homosexual. So now we've identified kind of a 3rd main sexual orientation, and that was bisexuals. So now let's talk about the sexual identities.
So as you can see, there's a ton of different flags here. So does anyone happen to know what this top flag represents or who the population that it represents? Probably not. So that is for Two-Spirit. And then you also have the allied flag at the bottom of this screen. But as you can see to the right-hand side, there's so many different types of flags that are up there. Everyone kind of wants their own identity flag. So just kind of keep that in mind if you ever see those flags out there.
And this is important, especially this time of year. It's June, it's Pride season. So you see a lot of flags out there. People see the rainbow flag that was first created in 1978. The real purpose behind this slide was that there's over 34 different gender identities that have been created thus far. It's a huge number. And so we can see it keeps growing as people find different nuances to express their gender identity and sexuality. So let's do a little bit of flag history. The rainbow flag is incredibly important to this population. It was created in 1978. Each bar of color has a specific meaning, as we can see here. Now, the old flag, the 1978 flag, is on my left here. If we look, the newer one with the triangles on it, that's actually the progressive flag that was first introduced in 2018. Now, the reason why this one's important is because it includes the minority colors of Black and brown. It's also important because it includes the transgender colors. Now, if you want to get real specific, I've seen this flag also done with the bisexual colors on it as well. And then if we were creating a flag or the next version of this flag, we would like to add a silver bar to it because the silver bar would represent the population over 65. Yeah. That population in the LGBT community tends to get just written off and not talked about. And we'll get into that later in the presentation, but it's important to acknowledge that there are LGBT people over the age of 65 and they're just as relevant. All right, so June is Pride Month. That's why we're doing this presentation. Most people are aware, you can see most corporate sponsorships tends to go rainbow for the month of June, which is great. It highlights a lot of LGBTQ issues. But it's important to know that these issues happen year round. Right. LGBTQ people happen year round and not just in June. So while we're very happy that you're celebrating now, it's important to keep in mind to do this all year.
And then, so another important date is November 22nd. That's the Transgender Day of Remembrance. So everyone comes together and they remember the victims of transphobic hate, those have died. And so we're there to amplify and kind of come together to fight this world of transphobia.
The next important date to remember is May 16th, and that's not honor our LGBTQ Elders Day. This is a new holiday as well, but in the springtime. And this is just exclusively for the older population so that we remember that they're still a vital part of this society and still need to be acknowledged. So that just came up on May 16th. So let's get into some science theory here. There's a theorem out there called the Gender Minority Stress Framework. And this is actually the basis of all LGBTQ healthcare. And so we're going to run through it. If you haven't heard of it, this concept kind of came about around 3 or 4 years ago. So I'll run you through it. So as an LGBT person, they tend to experience microaggressions every single day, multiple times a day. So now these daily occurrences start to compound over a lifetime, where every single day they're receiving some sort of stressor that increases cortisol levels, that increase stress levels, stress hormone responses. And we see that over a lifetime. Now, the individual might react adversely to this by smoking cigarettes, drinking alcohol, being sexually promiscuous, making, poor life decisions. Now, if we do this over a lifetime, 20 years, 30 years, 40 years, it's going to compound. And then that's when we start to see real health problems. We start to see, liver problem from too much alcohol. We start to see lung problems from smoking. We start to see cancer.
Everything.
And so it's important to realize that these are cumulative. And so we as family medicine work on prevention. And so now to better serve this population, we need to figure out how to prevent this. So we got a question. It says, what do? I have a friend who makes me want to hide my trans side. Difficult question.
Yes.
Short answer is find better friends.
Yes.
Without sounding too rude about it, it's important to not hide who you are. If you believe you are trans, you need to find yourself a social support network.
Yeah.
That's what we talk about in clinic every time we have a new patient. That it's important for them to find friends who are trans and to find other people who are trans to help them go through this journey.
Exactly, and always know who to reach out to. So we actually had clinic yesterday, we saw a few patients that were transitioning, stopped and started up again. You kind of have to just be open, know where your resources are, who to contact when you need them. And then also, like Dr. Estvold said, make sure you find a good support system from friends and family. And you know what, not everybody's gonna be agreement into what you want to do, whether that's your sexuality or your decision-making in life. Do what makes you happy. It's essentially your life.
All right, let's get back to the framework. So you want to talk about this slide?
Yes. So health disparities are linked to race. It's something that we all need to think about. So there was a study done in 2020 last year by Chandler about Black men having sex with men, and most of them were associated with sex work. So that's really interesting to think about. It's also a cultural thing. So a lot of the Black men don't want to actually come out and say that they are having sex with males. And they're also doing it alongside with work. So this is a big issue because in the community, wherever they're doing it, it increases their risk for STIs, and with STIs increases your risk for becoming HIV positive. Along with being sex work, there's always drugs that are always usually involved. So polydrug use, they deal with a lot of depression because they're keeping a lot of these things inside. Increased intimate partner violence, that's a big thing that can happen in this community. So making sure that you touch base with these patients, like how do they feel, are they safe? And then also more likely to be Hispanic are the ones that they're having sexual intercourse with. And a lot of these patients are practicing the bisexual behavior. So they're practicing one part of their life and then doing another. And then also most of these men report an annual income less than 10,000. Think about that. 10,000 is not much at all throughout the year. And so with not much income, means they're probably not going to seek help for any of these diseases or STIs that they have. So what happens is their health gets worse, obviously. And two, if they're having multi-partners or they're doing drugs or whatever the case is, that could then be spreading within the community as well. So something to think about, you know, the Black men especially have more issues as far as the sexual orientation than their white counterparts do.
Yeah. So to summarize, we've found that there is a link between race in the LGBTQ population and adverse health outcomes. They tend to be more at risk, like Priscilla was saying, for HIV, for having lower income, for assault, poly drug use, depression, and STIs. So it's important to do a lot of screening, and we're going to talk about those screening methods in just a little bit. So let's get down to the medicine. LGBTQ medicine is really all about inclusive care. LGBTQ people have historically been cast out of medicine. So now they're kind of having their moment, and now is the time to get them the tailored medical treatment that they need. So we kind of touched about this on the last slide, but there's actually a lot of discrimination within healthcare for the LGBTQ population.
Actually, I'll tell the story after I go through this slide, but it happens all too much, whether you think it or not. There's the WAY study that 53% of LGBT patients experience discrimination. That's a huge percent right there.
53, that's over half.
And then 70% of transgendered experience discrimination. That's even more. And they've experienced slurs, microaggressions, sexual harassment, violence, even going into the bathroom, they get harassed. 18% of them avoid healthcare. Imagine if you're going to be harassed or you know that people aren't going to be accepting of you, are you going to go? No, not at all. Ethical and racial minorities experience significant higher rates of discrimination versus whites. And I mean, I'm sure not even being LGBT, the races obviously probably feel that as well.
Yes.
And 1/3 of transgendered individuals experience negative outcomes in healthcare. And why is that? A lot of it has to do with the fact that the healthcare professionals or physicians don't know how to interact with them, how to treat them. And then also they themselves don't feel comfortable enough to communicate their needs, what they feel uncomfortable with. And as we all know, when you take history, when you see a patient, most of your diagnosis comes from the history.
Yes.
So if you don't have that trust between you and the patient, are you going to get your actual diagnosis or know how to work up the patient? And it's pretty interesting because Dr. Estvold had me do a, what did we do?
Undercover operation.
Yes, undercover operation. So my roommate and I came to AU actually, and we acted like we were a lesbian couple. And we came in and we were trying to see if they had paperwork or anything ready for patients of the LGBT community. I cannot tell you how uncomfortable I felt. I'm not lesbian, but I played the role as a lesbian. And I felt so uncomfortable because they had, the person up front at the desk had no idea what to do. She was flustered. She made me feel flustered. The patients in the room, in the waiting room knew what was happening. It was just super uncomfortable. And it's kind of one of the projects that Dr. Estvold and I are doing as far as just kind of educating everybody in the practice of medicine from beginning to end. So whoever they see from the start through the end of MAs to PAs, nurses, physicians, everything of that nature. So keep that in mind when you come across a patient, regardless of who they are. Be very open with them because these patients really experience a lot of discrimination.
And we'll give you tips and tricks to like kind of beef up your office. That'll be at the end of the presentation on how to just create a more inclusive office environment so you can have a better patient experience.
Exactly.
So I'm in the military. I'm a captain in the Air Force. So I've included several slides on military healthcare related to LGBTQ healthcare, which I kind of found some really interesting stuff. There are LGBTQ people in the military, so they require healthcare. But we've found that overall that there was a lack of knowledge within the whole military medical structure. And so that was one thing, was that there's no guidelines for treating LGBTQ service people. So that was a major finding. The next major finding we found was many of them have some sort of military sexual trauma. So while they're serving, something bad happens to them and they're not fully treated for it. The MSM population is the largest population within the military, within the LGBTQ spectrum inside the military. And so that stands for men who have sex with men. Then of course there are lesbian military service members, and there are actually transgender military service members. One thing was interesting was the Ford study that noted that there's actually no definitive transgender treatment guide for any of the military services, which is huge. It's a huge blind spot that I think they're working on now. So hopefully in the near future, we'll see how that gets remedied.
Yes.
All right, do you want to talk about
So heart health. So the American Heart Association in 2020, there was a study integrating health into healthcare curricula. So it's really interesting in the LGBT community, individuals experience higher increased health disparities comparatively to the cisgender population. So, and that has a lot to do with stressors. As we know, cortisol plays a huge role in your stressful life, but psychosocial stressors, all of that, all the hormones can cause a lot of internal issues inside. And then a lot of these patients tend to internalize a lot of their feelings. So what do they turn to? They turn to drugs, they turn to tobacco. And a lot of these patients also, especially the lesbian population, have an increased BMI. So that also increases the risk harder for the heart to pump through. And then possible cardiometabolic risk with the hormone replacement therapy. So increased risk due to the hormones in general. And they have an increased risk for developing type 2 diabetes, especially in transgender patients.
Yeah. So this was a great study, the Kisera study in 2020. It really was a landmark study because it was the first time the American Heart Association looked at the LGBTQ population specifically, and then looked at them in terms of heart health outcomes. And so these were 5 really interesting findings that they found, as Priscilla mentioned, related to tobacco use, related to BMI, related to cardiometabolic effects while on HRT, and related to diabetes. And so we've actually used this information to change how we treat patients and screen patients within Equality Clinic, which is our transgender clinic here. So let's talk about women's health.
So the lesbian, queer women, and female health in general. So just keep in mind that when you're treating a lot of these patients, don't forget to look at them as what they are. So even if they're transitioning and stuff, you still have to keep in mind all of the female anatomy and things that they need to be aware of. So basic medicine, but social determinants of health, queer women are less likely to seek healthcare preventative services. And as mentioned before, it's because of the feeling of uneasiness, not feeling welcomed, something like things along that line. They're more likely to receive inappropriate care, and has a lot to do with our side. A lot of healthcare professionals don't know how to treat them. They think, oh my God, we have a LGBT patient, what do I do?
Yep.
But instead of trying to figure out what to do, they just kind of
They blank,
or they are like, oh, I can't treat you or whatever. And it becomes very uncomfortable. They're less likely to have healthcare. Why is that? Think about it, insurance. A lot of patients have issues getting insurance, even as students. I'm sure some of you guys have experienced or will experience the fact that, oh my God, I need to get insurance through school, or that it's not great. So it's expensive. Healthcare is expensive. They often enter the healthcare system at an older age. So they tend to kind of push aside whatever issues they have that compounds over the years. And then down the road, they end up having to be admitted. And then now we're no longer in the preventative stage. Now we're here trying to figure out how to prevent it from getting worse or keeping them stable. So things to think about. Health consideration, this population tends to be overweight. They have increased risk of diabetes, alongside of that, increased risk of cardiovascular disease, increased risk of COPD, because 200% of them are more likely to smoke tobacco. How crazy is that number? Increased use of alcohol and substance increase of hypertension, sleep apnea, all deals with obesity and not taking care of themselves. They have increased risk of cancer due to the prolonged exposure to estrogen over time. And what you need to also think about too is fertility considerations. So especially transgendered patients, especially if they're transitioning from the beginning or younger, you want to talk to them about what are your fertility, future plans. A lot of them don't think about it, but you kind of have to get that boiling in their head to see if they want to preserve their eggs, things like that.
One thing to think about within the lesbian population, most of them have not been exclusively homosexual their entire lifetime.
Right.
There is a good chance that they've had a male sex partner. And so you have to keep that into consideration.
Mm-hmm.
That makes you think about screening for things like HPV.
Right.
So those are just things to keep in the back of your mind as a provider, to do a real good, thorough sexual history, just history on them in general.
Women's medicine. So preventative screenings, you're going to want to do everything that you normally do, lipid panel, hypertensive, hemoglobin A1C levels, screen them for tobacco use, alcohol use, substance abuse. I mean, pretty much how you would screen anybody. Have them do pap smears, mammograms, talk to them about birth control. Mental health screening is huge for this entire population in general. So making sure that you ask them, how do they feel? Are they feeling okay? Do they feel safe? Do they have a good support system? And then, also safe sex practices is very important as well.
So we did get another question that came in and asked, is there a higher incidence of metabolic syndrome in the LGBTQ community? I'd have to say yes. And if we go back to that previous slide from the Caceres study in 2020, done by the American Heart Association, it did show that within some populations in the LGBTQ population that you are at an increased risk for cardiometabolic effects. So basically it's important to see your PCP and it's important to have or to make good diet and lifestyle choices, or else it will catch up with you.
Yes.
One thing I also wanted to point out in this presentation, Priscilla and I really tried to use pictures that showed people of color, different minorities, different ethnic groups, not just your stereotypical white LGBTQ people. So we hope you guys appreciate that. So now let's talk about men's health. Men's health encompasses a lot of people. It encompasses the gay population, the MSM population, and that's men who have sex with men, and then queer men, so people who don't identify in either of those two populations. And it's kind of important to tease that out. Not all men who have sex with men identify themselves as gay or queer, but they're still having sex with men. So we have to be able to incorporate them into our healthcare. So let's look at their social determinants of health. Again, they're less likely to seek healthcare. Most of them can't afford it, or they're not in a position where they can get good healthcare. We see this really crazy twin effect of racism and homophobia together within the queer community. It's a really unfortunate side effect where if you're gay and Black or gay and Asian, you receive racism within that community.
Yes.
It's terrible, and hopefully it's being worked on to get better. We also see classically, like we see in normal healthcare, that Black and Latino population is disproportionately affected versus the white population. We also see that resources for healthcare tend to be allocated more towards white patients rather than Black patients or Latino patients. These within the gay population tend to be single, they tend to be estranged from their family, but they tend to have a social support network called a chosen family, which means they've found their tribe or their people, their friendship circle that they tend to be very close with comparative to their biologic family. So let's look at their health considerations. With the men, they're 50% more likely to use tobacco versus the 200% in the lesbian population. So we still need to screen for tobacco. They're much more likely to use alcohol. They're much more likely to abuse substances like club drugs and things. They're much more at risk for depression and then for suicide. Gay youth are particularly susceptible to suicide. There's a much larger risk in this population for contracting STIs. There's a much larger risk for anal cancer, and that has to do more with anal sex is more prevalent in this population. Higher HIV incidence. We know this historically, we know this from the HIV epidemic, but despite having this huge push for education and this vast amounts of resources being driven towards HIV prevention, we're still seeing more new incidences of HIV, especially in the younger population and in the older population. And then this group is particularly susceptible to eating disorders and body dysmorphia. And that all plays into this idealized image of what the ideal male or queer male needs to look like, and then everyone being hard on their bodies to try and fit that image. Let's jump into the medicine of it. So what do we screen them for? Like I mentioned earlier, we screen for tobacco, alcohol use, substance abuse. These are all basic screening questions. We want to screen for STIs like HIV, gonorrhea, chlamydia, syphilis. It's important to screen all orifices involved. So that's why a good thorough sexual history is important. We're not just doing blood draws, but we need to do, an anal pap or an anal swab for gonorrhea or a urethral swab, even a throat swab. Wherever there was sexual activity, we need to swab it. Important to screen for Hep A, Hep B, Hep C, HPV. Everyone can get vaccinated from HPV from the age of 12 to 47. So if you're at risk, definitely get it. HPV happens anywhere that semen goes. So if semen can go someplace, you can get HIV there, or HPV there, excuse me. One thing that was really interesting is there's there's the use of social media and the gay social hookup apps to get medical information out there. So at the top of the screen, you can see the icons for some of the dating apps. And those have been instrumental in actually getting people to HIV resources, to PrEP resources, and then to provider resources in the area. So that's something that's really cool. One thing we really want to talk about is the use of PrEP. I don't know if any of you guys have heard of PrEP out there, but it stands for pre-exposure prophylaxis. It's the once daily pill you can take to prevent HIV along with condom usage. PrEP is great. PrEP's been around for about 2 years. There's two major brands of it. There's Truvada and Descovy. They're virtually the same. Side effects tend to be very minimal. I think the only difference between the two is that Truvada was tested in men and women, and Descovy was only tested in men. And I could be wrong about that, but it was a subtle difference. So it's important to figure out who is a good PrEP candidate and get them on it immediately. PrEP's very easy and very well tolerated. All you have to do is have a HIV test, and you have to have 2 consecutive negative ones so that it's ruled out that you do not have it. So you can start them on PrEP. And then every 3 months, you want to retest the patients and get their lab work. So you want to do a CMP, a CBC, and then STI testings every 3 months. So PrEP's a great tool. Only about a quarter of the LGBT or the MSM population who are PrEP candidates are actually on it. So we need to push to get more people on PrEP. Looks like we have another question.
Has the emergence of PrEP had any impact on the prevalence?
A little bit on the prevalence of HIV, is that asking? In terms of HIV, definitely. We have seen a decreased incidence of HIV. That definitely has some to do with PrEP. Because our overall PrEP numbers are low comparatively to who can be on them, we do have much more room to grow in that aspect. What about the new monthly injection for PrEP? Yeah, so the injectable PrEP, that's not widely on the market yet. I think it's still being researched. That's supposed to be monthly or every 3 months, almost like a depot shot. And that's great. If you can take it, it goes in your deltoid and then you're good to go for 3 months, of course, with condom usage. But it's not widely on the market yet. So I think it's mostly being tested and available in more metropolitan areas.
I think eventually that would be probably the more expensive route.
Probably more expensive, but hopefully more people will get on it because you don't have to think about it every day. It'd be very exciting when it becomes mainstream. All right, the bisexual population.
So almost 5% of people identify as bisexual. Over 15 million people in the United States are bi, and 40% of the LGBT people identify as bisexual. So, we talk about it's not just a phase, and bisexual health in men and women. It's actually very interesting.
It's also a huge population. That's why we bring it up. It's not just a sliver of the LGBTQ population. It's a majority of them.
Some considerations to think about. So health guides, you still have to think about prevention and health guides as it pertains to their biological sex. And then digging into asking them the right questions and asking them, who do they have sex with? Males, females, both. Super important into making sure that you're screening properly and educating them as well for safe sex use. The use of USPTF guidelines, follow those. Bisexuals are at extremely high risk for depression and suicide as opposed to all the other groups. So really think about that, really need to get them on PHQ-9s, talk to them, make sure they have someone to talk to if they need to. And a lot of that may have to do with the fact that they just aren't sure which route they want to go, or they don't know if they can really come out. A lot of things come into play when it comes to the depression and suicide. And then also those that are at risk, consider and prescribe PrEP for them.
And the USPSTF guidelines, if you don't know what those are just, it stands for the United States Preventive Task Force. It's kind of like the main guide for prevention in medicine for the US. As family medicine docs, we use that all the time when screening people. And it basically looks at like your age and your sex, and then your risk factors and what we should be screening you for. And so that's a great jumping off point, because it screens you for like tobacco, alcohol, HIV if you're at risk, and then what we can do to better provide you a more tailored healthcare. So let's get into transgender health. Does anyone recognize these two here? Possibly. So the woman on the right, so that's transgender female Laverne Cox. She's from the show Orange is the New Black. She's one of the most famous transgender women in the world. The reason why I put her there is because not every transgender person looks like that. Transgender people look like everyone else. Some of them have fully transitioned and they're passing in society, which means you can't tell the difference. And then some people have not, and they look like their original body, and that's completely fine. The guy on the right is a transgender model named Ashley Lath, I believe. Super successful. This is one version of what a transmasculine man can look like. Not all of them look like that, some of them do. So it's important to remember that transgender people look like everyone. So let's go over pronouns. This tends to be like the most dreaded thing, and the biggest question that we receive is, I'm too scared to interact with a transgender person because I don't want to call them by their wrong pronouns and offend them. And then you don't provide any healthcare to them, which is wrong.
Yeah.
Gender pronouns is just, how do you identify yourself? And so as a female, you would identify with
she, her, hers.
And then as a male, identify with he, him, his. Transgender people, or some people, identify as they, them, theirs. That's very gender neutral. If you just practice it, like you can use they, them, their almost every single time as just like your default when you don't know how someone identifies with their pronouns.
But you can easily just ask that when you walk into the room. What is your preferred pronoun?
Yeah.
It makes it so much easier.
And pronouns are starting to get put on like the end of people's emails, text messages, like name badges all over the place. And it kind of just shows that people are thinking more of the idea that people can be more than the gender they express.
Right.
And so it's a really cool concept. I put the other grid on the other side of the presentation to show you that you can overcomplicate this, and you can use the ZE, which I think you pronounce Z, and then XE, which is, I don't even know how to pronounce it, but you can overcomplicate it. Or you can just use y'all. We're in Georgia.
Yeah,
that's what's the joke. Just use y'all when in doubt. It's very gender neutral. So do you want to talk about the social determinants?
So social determinants of health, they're much more likely to be victims of violence, much more likely to be murdered. So actually kind of hits close to home. A few presentations ago that we did, one of our transgender patients from Equality Clinic actually was a victim of that.
Was murdered.
Yep. So it's pretty close to here. Much more likely to contract HIV. And then of course, with more exposure to sexual STIs, obviously increases your risk for HIV. Much less likely to have health insurance, as we've talked about before, as far as money and a lot of these patients too, if they are married, sometimes they don't even get the partner insurance benefits. And as we know, in general, insurance has been a big issue for a lot of people. A lot of people work, so they have insurance, healthcare insurance, but sometimes it doesn't end up being something that they can get. They get extreme social isolation. It has a lot to do with the community around them, how they feel with the people that are, if they're accepting of them or not. And of course, if they're starting to come out, do they have the support system there? So extreme depression, suicide, behavioral health risk is huge in this population.
And I'm going to touch on health insurance real quick. It's an interesting concept that your health is linked to your health care. Your health care is then linked to your health insurance.
Right.
So if you can't get health insurance, which most individuals get health insurance either through marriage, because their spouse has a job that provides them health insurance, or through work.
Right.
So if you don't fit into those two social constructs of being able to marry someone or be able to hold down a job that can provide you health insurance, you then don't have health care provided to you. You then have poor health outcomes.
Right.
And because in the US, we don't have universal health care, we tend to see this population ending up in the ER or ending up with chronic problems that could have been prevented in the first place because they didn't have access to health care and health insurance.
Right.
So interesting. More on suicide and depression.
So 48% of all transgender adults report that they have considered suicide in the past 12 months compared to 4% of the overall population. So this population has they're twice as more likely than the heterosexuals to experience mental health conditions and issues. And, like Dr. Estvold said, a lot of them don't even have insurance, so they don't even know where they can go or who they can talk to. And that's really sad. And so we really need to focus and pay attention to their mental health, especially.
And if you guys didn't catch those numbers, I'm going to just reiterate them for you. That's 48% of all transgender individuals. Round that up to 50% of all transgender individuals versus 4% of the overall population. That's an insane disparity with depression. So it's important that we really ask these patients about their depression. This is Miss Spain 2018. She was the first transgender woman to win a pageant title on the international circuit. So that's pretty cool. As you can see, she's a transgendered woman, and this has never happened before. So that's why we threw that picture on there. So let's talk about the medicine. So this is what we do at Equality Clinic, where we primarily focus on HRT, hormone replacement therapy, which is a fancy way of saying helping someone transition to the gender they want to be. So we still do all screenings that are based on biological sex. So if you have a cervix, you still need pap smears every 3 years or more frequently. If you have breasts, you still need breast exams. So if that tissue is still present, it's important to take care of it. Like we just talked about, screening for depression. We screen almost everyone with a PHQ-9. And if they come and see me in clinic at Family Medicine Clinic, I screen everyone with a PHQ-9, whether they're depressed or not, or state that they're depressed or not. It's important to start tracking those numbers and collecting that data so we can see if they're getting depressed or if their depression is getting better. It's important to ask if these patients are or participate in sex trade or if they have gender dysphoria. Gender dysphoria, for those who don't know what that is, that's dysphoria or depression linked to you not being in the body that you think you're supposed to be. So it's that incongruency that we see. So if you're male, but you have a female body, you're going to have gender dysphoria because you're not what you feel that you truly are. We need to ask these patients about intimate partner violence because that happens a lot in this population. We need to ask if they feel safe at home. We need to ask them about PrEP. If they're a good PrEP candidate, are they ready for it? We need to break down as many healthcare barriers as we can to get them seen by a physician.
Exactly. And also don't forget about the different age groups that you're dealing with and what they're more exposed to. So the younger age group, you want to talk more about how is their sex practice, but then when you get into the older population, have they done their health screenings such as colonoscopies, things of that nature. Don't forget about the very basics.
So let's talk about the nitty-gritty of transgender medicine. This is what I do. This is what I've been doing for over 2 years now here in Augusta, and I love it. So let's talk about the transmasculine men. So that's someone who was originally female and wants to transition to male, are transmasculine men. We give them testosterone. It's very easy. They do a testosterone injection every 2 weeks. We track their labs every 3 months. The labs we're going to get on them, we're going to do a CBC because we want to look at their hematocrit to make sure that their red blood cells aren't getting too thick in their bloodstream and can cause a clot. We want to look at a CMP because we want to measure kidney function, make sure we're not affecting the kidneys, and then liver function. We want to look for liver enzymes to see if they're rising or not. And then I always like to track their testosterone level to make sure that it's rising appropriately, and then their estrogen level to make sure it's bottoming out appropriately. We can also get a lipid panel on this patient population to make sure that there's not too many lipids in their bloodstream. And then of course with these guys, it's important to give them their pap smears because they will try and avoid it like the plague.
Yes, they will.
At the clinic, we've been testing out a pilot program where we do self-administered pap smears, in which we teach you how to do a pap on yourself. You collect the sample and then we'll send it off to the lab.
Yeah.
And it's been wildly successful.
Because a lot of them feel really uncomfortable going into OBGYN office and getting that done. So
yes. And then with our trans feminine women, really easy to transition them. We start them off on about 2 milligrams of estradiol, and then we increase that over a 4-year period. We can also start them on spironolactone, which at low dosage, we all know is used for hypertension. And then at higher doses, it can be used as a testosterone blocker. We can also start them on progesterone later into their transition to help kind of boost up their estrogen levels. And then it's basically the same lab, CMP, to make sure liver and kidneys are functioning well, estrogen level, testosterone level, lipid screen. We've started screening people for diabetes if they're at risk for it. And then absolutely no smoking if you're on estrogen. That's the same reason why you can't smoke and be on OCPs, because the nicotine in the tobacco can help you form a clot that can go to your brain and kill you. So we screen everyone for tobacco and we harp on them why it's important to not smoke tobacco.
the aging population of LGBT, this is my favorite. So we call this the silver population, all those above 65 and older. So a few interesting facts: 1.1 million LGBT adults are in the US are 65 and older. That's a lot. They're twice as likely to be single as they age. And that has a lot to do with the fact that they're starting to come out as they're older. 3 to 4 times less likely to have kids that support them or family that supports them, period. 1/3 of the LGBT older adults live in poverty, twice as likely to live alone, and less likely to disclose orientation in healthcare settings. Especially now, a lot of the 65 and older population at their time when they were younger, they weren't really allowed to come out. They didn't feel welcome enough to come out. So now that they're getting older, they're still afraid. And this goes back to the healthcare settings and the fact that they don't feel comfortable coming out to their healthcare providers, and they should feel comfortable. We should be the safe space for them. It shouldn't matter what they're doing. They should still be able to tell us. We should have we should be there with open arms, there to treat them as a patient, as a human, regardless of their sexual orientation. So 92% of 65 and plus do not use condoms. And 53% of people between 65 and 75 years old are still sexually active. And 26% of people between 76 and 85 are still sexually active. So you still need to do STI screenings, educations that are super important. You see a lot of STI kind of rise in nursing homes. So something to really think about. And then also even patients that are within this age group and they're not in nursing homes. There's been a few articles out there, I think particularly Lindau's article, stating that sometimes one partner is not as sexually driven as the other. So that other partner will go and do their business elsewhere, then come back. That's still has a lot of increase of risk of exposure of STIs. So don't be blinded by it. Don't be blinded, oh, because they're older, they don't do these things. Everyone's human, everyone has their different sex drives. So really push the questions and sexual safe practices, and then screen for them as well. This population still needs care. So I don't know about you, but sometimes, and I do this occasionally, I think of the LGBT population as more of the younger age group. And maybe that's because the younger age group is pushing more for equality between the LGBT population. I'm not sure, but we tend to forget about they do age. We do have LGBT patients in the older community. So a lot of these patients have a lot of aging fears. They feel they're afraid of rejection, discrimination within the healthcare system, and in long-term care, especially. They have disparities in cardiovascular risk compared to their heterosexual population. That has a lot to do with the fact that they're even more stressed. So that compounds onto everything else. Mental health is still important in this population due to the ongoing life of coping and keeping it quiet, maybe turning to substance use because they're unable to come out about it. And then of course, screen for STI, hepatitis, cancer, and cardiovascular disease.
So what are we doing here at AU? Priscilla and I have been working overtime.
Yes.
We've done some really fun things. We've created a poster, a badge, a resource brochure that we're gonna go into and show you guys. So this is our LGBTQ medicine care guide that we developed together. It's a poster that has gone up all over the hospital. As you can see, it breaks down each population and kind of gives like facts, like medical facts that you need to know about them to provide better care. We also did like a little takeaway section. So like if you're just a flustered provider, you had no idea what to do, like this is what you need to know, right? These facts. There's a lot of gross generalizations on it, and that's fine because they provide good jumping off points for you to provide better care. And so it kind of sums up a lot of what we've talked about in this presentation. And then we've actually sent this poster out for a lot of conference presentations, and it's been very well received. The badges.
Yes, which we both are wearing. And so this essentially gives patients, lets patients know that this is a safe space. So they will see the flag kind of pop outside. It's a little bit wider than a normal ID badge. So it's an identifier for patients, but also a quick guide for healthcare providers like, oh, I have an LGBT patient, what do I do? Oh, quickly, I need to screen for this. These are the labs I need. These are if they're transitioning, these are the basic dosages that I need to give. So it's a really neat badge tag that we developed, and actually everybody loves them.
They're all over the hospital now. They've been widely distributed. If you want one, go ahead and contact jmoretz@augusta.edu. That's that email at the bottom of the screen, because she's taken care of a lot of them. And yeah, they're really handy, really fun. Basically, like my counterparts have said that like when they get in a room and they're not sure what to do, they just check the badge really quick and they know how to prescribe.
Yeah.
Done. Easy. This is a brochure that we're working on for AU, just to kind of like the poster and the badge, but this can be given out to both patients and to providers. And again, it has like medical facts that you should know, like different health screenings. It's just kind of a different format. If people like a brochure, it's the brochure format. And it includes like, you know, little fun facts and things. So this is still in the works. So Equality Clinic.
Yes, which we actually had yesterday. So 2 Wednesdays out of each month, we get together, and it's actually run by the AU medical students, and I'm the non-AU medical student that goes. But basically from 5:30 to about 9, we see these patients from all over the CSRA area. People have traveled from Florida, South Carolina, North Carolina, North Georgia, South Georgia, all everywhere and anywhere. A lot of these patients don't have insurance. They don't really have, or they're from rural Georgia, where they don't have anywhere or no one to go to as far as healthcare. So they come to us for basic screenings, but then also help them transition into who they feel they need to be.
Yeah.
So it's actually really great. The patients are super nice. It's really life-changing, really, because they come to you with, they have a lot of anxiety, but you ease that anxiety because you're educated, you know how to approach them. They feel like they're being listened to and they're being treated well. So they come, there's a wait list.
We're booked out about 6 months in advance.
Yes. And
Unless we slip you in, which just means the word of mouth of this community has been astronomical,
Mhm.
and we
It's
love our
great.
patients.
it's so great.
So here's other resources. SAGE is a resource that you can use for LGBT elders. GLAMA has a great directory, so you can find providers near you just by putting in your zip code. It's not a very comprehensive directory, but if you're a physician and you've registered to it, then you'll show up there. Trevor Project also provides a lot of youth resources. So what can you do for your office space? What can you do as an individual? What can you do as a med student? The easiest thing is to provide some sort of rainbow clue that patients can see, and they can identify that you're an ally to the community with them. A lot of times, like we talked about the badges, we have it, wearing some sort of pin, some sort of any rainbow identifier really helps out patients. They notice it right off the bat.
They really do.
It's very effective. In your office, if you have like stickers, flags, pins, anything like that, immediately creates a safe space for patients.
Update your clinic. So like I said before, we did that undercover thing. You gotta train everybody, staff from beginning to end. So anyone who works the phones, welcomes them in, educate your staff, make sure that they don't feel uncomfortable or they don't know what to do. Make sure you have intake forms that are ready for these patients or all patients, to make them gender neutral questions. Post a non-discriminatory policy, gender neutral bathrooms, which I think people have probably start to see as they go out, restaurants, things like that, and have brochures for them. And have, as a physician or future physician, by making sure you have your resources on who can I send these patients to if, in case I need to send them for X, Y, and Z.
Yeah. It's important not to have just like AIDS related brochures, because that's what everyone thought LGBTQ medicine was just, HIV AIDS medicine. And it's not, it's a full spectrum of medicine.
Yes.
So here's our references. We are nearing the end of the presentation. So if you have any questions, I think we had one question come in asking about biological sex for a transgender person and what does that refer to? Biological sex, usually in our purposes, refer to what they're presenting as now and what we're treating them for, not their sex assigned at birth. So their biological sex now could be female, it's a transgender woman. At birth, she was assigned male, if that makes sense. It's a little bit ambiguous, but basically like the rule of thumb that we use in clinic is that if you're presenting one way or you've told us that's how you want to present, that's what you newly are. And then physiologically, we will transition you to that. Well, I really hope you guys enjoyed this presentation.
Yes.
If you have any questions, please let us know. And feel free to contact us. We love giving this presentation and we hope you guys learned at least one new thing for LGBT Medicine Bootcamp.
Yes.
So thank you very much.
Thank you.